everyone. I'm going to be spending the next 20 minutes talking to you about how to prevent kidney stone disease. I did my fellowship at Duke University and trained under Dr. Preminger, who taught me about medical management of kidney stones. So the American Urological Association states that any patient that has a kidney stone should be screened to determine whether they should receive either a basic or comprehensive evaluation. The screening evaluation requires you to take a good dietary and medical history, get some blood tests, always at least get a urinalysis, also obtain a urine culture. If a stone is available, it should be sent off for analysis. And ideally, you have some type of X-ray or imaging study so you have a sense for stone disease. As I said, blood tests would involve Chem7 with a calcium and uric acid level. And when would you obtain a ionized PTH? Well, that's only if you suspect it. There are three situations which you may suspect a PTH. Either they have hypercalcemia, or they have a high normal calcium, if they make a calcium phosphate stone, or on the x-rays there's evidence of nephrocalcinosis. If available, like I said, the stone should be analyzed. The best test would be either x-ray crystallography or FTIR, infrared, get the terminology, but it's FTIR analysis. Wet analysis can be very unreliable, unfortunately, though that's the most common form of analysis. The type of stone can tip you off to the underlying process. Obviously, cystinuria would explain that problem. A uric acid stone means that typically the urine pH is very low. This is a very commonly misdiagnosed problem that I see. People have uric acid, and we'll talk more about this here in a little bit. The presence of a struvite stone obviously means recurrent infections. Calcium phosphate, as I alluded to earlier, suggests maybe primary hyperparathyroidism. It can also mean there's maybe distal renal tubular acidosis, medullary sponge kidney, or perhaps there's the iatrogenic use of carbonic anhydrase inhibitors, or even the medication called topiramate, which is typically used for migraines or seizures, commonly known as Topamax, the trade name. So after you've done the evaluation, how do you determine whether someone should get a comprehensive test or just get some general guidelines? Well, we definitely want to do a 24-hour urine test on these people if they've had multiple stones, recurrent stone formers. So they've had more than one, they've already had one stone, now they're having their second stone. That's an indication. Or if this is their first stone and there are some risk factors present. For example, they had their first stone, but they tell you that there's someone in their family has stones, or they had the presence of a GI or bowel disease or a bowel surgery in the past, history of gout, type 2 diabetes, obesity, imaging studies suggest nephrocalcinosis, history of recurrent infections, and oftentimes we have these fad diets here in North America where people are taking very specific diets in an attempt to lose weight. Relative indications would be if they're a child, or if they only have one kidney, or if they simply tell you, look, I really want to know and I'd like to do the 24-hour urine test. That's an acceptable reason to do it. Keep in mind, like I said, there are some medications that may put them at risk, and so you should always ask about medications. Common ones that I've seen are topiramate and vitamin C. A lot of people are taking vitamin C recently because Dr. Fauci of the National Institutes of Health takes 1,000 milligrams of vitamin C for COVID prevention. But 1,000 milligrams of vitamin C is a very high dose, and that can lead to stone formation. So if you're not going to do a 24-hour urine test, let's say they have no real risk factors, they're just a first-time stone former, they don't want to do a 24-hour urine test, what do you tell them? What do you do? Well, you can do some basic things. Number one, tell them to have normal calcium intake. Sometimes patients think, oh, I made a calcium-based stone, I should avoid calcium. That is actually incorrect. You don't want to avoid calcium because if you avoid it, you will paradoxically increase your risk of calcium-based stones. Number two, you don't want to avoid oxalate. Oxalate's found in a lot of healthy foods. A lot of vegetables have oxalate. You just want to moderate it. And I would say this is the least important restriction. I rarely tell people to really avoid oxalates. The third thing is meat intake, particularly in North America. This is a problem where our animal intake is very high. So I always tell people don't eat anything bigger than a deck of cards. If the meat is bigger than that, just cut it in half and save it for the next day. In fact, you might want to consider maybe a vegan or vegetarian diet once or twice a week, or maybe at lunchtime just have vegetables only. The fourth thing that's very common again in North America is sodium restriction, because we know that sodium stimulates calcium excretion. So if you can limit your sodium intake, you may reduce your chance of calcium stones. And the last one is the most obvious, is you want to increase your fluid intake. This was a slide from Dr. Ralph Klayman at the University of California, Irvine. Dr. Klayman says you can drink whatever you want. There's only two things you can't drink. Number one is dark colas, and number two is things high in sugar. Other than that, he says, I don't care what you drink to prevent stones: beer, wine, coffee, tea, sodas, juices, whatever, as long as it's not a dark cola and as long as it doesn't have a lot of sugar in it. 100 ounces a day is ideal. So let's say the patient does want to have a comprehensive evaluation. You can do one or two, it doesn't really matter. 24-hour urine tests. These are the things you want to measure. The total volume. Definitely want to always make sure the 24-hour urine checks the pH. That's important. Obviously, calcium, oxalate, uric acid, and citrate. These are the big four. Sodium is important because, as we'll see in a little bit here, sodium affects calcium, so it's important to measure the sodium. Potassium is a good one to check because a lot of the medications we give these patients are potassium citrate, so it's a good way to check to make sure they're actually taking their medication if you check the potassium level. And the creatinine is important because it's a measure of an adequate sample collection. As I mentioned to you before, this is probably the most important thing that I've seen at least in the United States, is I find that a lot of patients have a lot of salt in their diet. And this is the most important thing I can tell them, is to really cut down their sodium intake. If they cut down their sodium intake, they usually excrete less calcium. A lot of my patients say, well, I don't put salt in my doctor. And I say, of course you don't put salt in your food, because it's already in your food. It's the food you buy. A lot of it has a lot of salt in it. If you look at the package labeling, if it's in the first top three ingredients, you probably should be careful. If you go to a restaurant, you also want to tell them to have low sodium, because a lot of restaurants pour tons of sodium into the food because they don't know how to cook. So that's how they make it taste better. They just put a lot of salt in it. Again, I don't know if that's true for Ghana, but that's very common in the United States. So here's an example of a 24-hour urine study. Let's go through it so we can learn about it. This is a 49-year-old gentleman who is treated for this. He's had 2 stones, so he's a recurrent stone former, and he makes calcium oxalate stones. What you can see here is that he's pouring a lot of calcium into his urine, 330. The upper limits of normal is 200. He's also got a lot of sodium in his urine. Upper limits of normal is 200. So this is the obvious problem. He has occult sodium in his diet. Of course, he will tell you he doesn't put salt in his food, and you say, of course you don't. It's already in your food. And as soon as we change that, so the treatment should consist of decreasing your sodium intake. Decreasing your sodium intake. And once you change this, and this is the important part for you guys here, is to make sure to repeat this test. Once you repeat it and this actually comes down, more often than not, the calcium will come down. and they won't form stones. So this is a pearl I'm trying to give you. Dietary therapies. Again, like I said, you want to limit your intake of oxalate, but you don't want to avoid it. Avoiding oxalate would be really difficult. Plus, most healthy foods have a lot of oxalate, so just moderation. And then you also want to make sure you're not avoiding calcium. So a lot of dairy products have calcium. So a moderate amount of calcium is important. The calcium will bind the oxalate. So if you avoid calcium, you will paradoxically increase your risk of stone formation. Here's another example, a young man, 31-year-old, he's past his fourth calcium oxalate stone. He says he's a vegetarian. He takes milk with cereal, so he's got some dairy in his calcium in his diet, but he avoids all cheese and yogurt. So maybe that's a warning that he may be deficient in calcium. His serum chemistries are normal, and his 24-hour urine is below. And what you can see here is he's spilling a lot of oxalate into his urine. Why is that? Well, the question is, what is the next step? Well, what should we do with someone who's a vegetarian? That's a lot of oxalate probably in his diet, and he avoids some dairy products that have calcium. As I've told you, calcium binds oxalate in the gut, so you need to make sure there's enough calcium in the diet. So we want to have him kind of limit some of his oxalate-rich foods and encourage him to consume a normal amount of calcium, about 1,000 milligrams a day. That way the calcium will bind the oxalate and he won't form the calcium oxalate stones. Okay, clinicians should encourage patients with calcium stones and a relatively low citrate to increase their intake of fruits and vegetables. This is another common one, to measure the citrate. Make sure you look at the citrate in the 24-hour urine. And if they have low citrate or hypocitraturia, just a simple fix is to tell them to increase your intake of fruits and vegetables. Number one, fruits have a lot of fluid in them, so they'll drink more fluid. Number two, they're loaded with potassium, and potassium will then lead to citrate excretion in the urine. So, okay, and the next thing is you want to tell them to limit their intake of non-dairy animal protein. So basically anything with a face has a lot of uric acid in it, so be careful. Actually, fish has the highest amount of uric acid, interestingly. I'm not saying don't have fish. I'm just saying if you make stones, you need to be aware that eating fish every day is probably not a good idea. So all forms of animal, anything with a face has, it will break down to uric acid. Okay, so what if you've done all the dietary things and they still make kidney stones? What should we do? Well, there are some medications you can offer them. I try to avoid this. I find that if I'm aggressive with my dietary management, then oftentimes these patients don't need medications, but sometimes patients still need medication. And again, I think one of the most important things for you to do is you have to repeat the 24-hour urine. If you don't repeat the 24-hour urine, you might as well not even get the 24-hour urine. It's kind of like diabetes. If you're going to check someone's insulin only one time, don't bother. You have to recheck your outcomes multiple times in order to really help someone change their diet. Okay, so what if they're hypercalciuric and they spill a lot of calcium over 200? The treatment is a thiazide. What if they are low in citrate or have hypocitraturia? The treatment is potassium citrate. What if they have a lot of uric acid in their urine? Hyperuricasuria, the treatment is allopurinol. What if they have a very acidic urine? What we call gouty diathesis. And it's called gouty diathesis because typically kidney stone formers who make uric acid stones oftentimes have gout. So the term is coined gouty diathesis. Anyway, the treatment is like hypocitraturia, potassium citrate. Let's go more into this here. All right, so here's a young woman, 36, who's passed 3 stones. She's got a normal calcium, normal creatinine, and normal PTH. 24-hour urine shows what? She should increase her fluid intake and do what else? Well, definitely increase the fluid intake, right? She's only urinating less than 2 liters a day. Well, she's got a lot of calcium in her urine, 300, well over 200, right? So we first look at the sodium. That's the first thing you always do. Sodium looks fine, so that's probably not the cause of the hypercalciuria. And assuming she doesn't have any dietary sources of excess calcium, then you might want to consider a diuretic, right? A thiazide diuretic like HCTZ 25 milligrams a day or HCTZ 50 if they don't respond. Keep in mind, diuretics have some side effects. It can lead to hypokalemia and also hypocytituria. So you may fix the hypercalciuria and then inadvertently create hypocytituria. Again, repeat the 24-hour urine. You have to repeat that. I can't emphasize how important that is. If you don't repeat the 24-hour urine, don't even bother getting it. Okay, so you may need to supplement these people with potassium citrate after you start thiazide, unfortunately, but you wouldn't know until you repeat the 24-hour urine. The next of the four here, and then we'll be done, is citrate. If they have hypocytituria and they don't respond to dietary modification, you need to start them on potassium citrate. Citrate is an inhibitor of stone formation. So here's a 35-year-old man with hypercalciuria. He continues to make stones despite taking 50 milligrams of HCTZ. Let's look at his 24-hour urine. What we see is, all right, his hypercalciuria is treated, so HCTZ is working. But like I said, we've created this hypocytituria iatrogenically, and you've repeated the 24-hour urine. That's how you know that, right? And so what is the treatment? The treatment is you want to check the potassium level because we know that he's wasting potassium from the HCTZ, and start the patient on potassium citrate so we can get that citrate level up. And until you get this up, they'll still continue to form stones. The third of the four things is hyperuricasuria. This is probably the least common thing that I see, I will tell you. But if you should see it, keep in mind the diet usually is the cure, but if they can't stop their high animal intake, then allopurinol is reasonable. I had a patient that day who told me, I said, you should cut down. He eats a lot of meat. He goes, I don't want to stop eating meat. I said, okay, if you don't want to stop eating meat, then you have to take the medication. He says, that's fine with me. I'd rather take the medication to eat my meat. I said, okay, so be it. And then the last one, this is a pearl. If you can always look at the urine pH on a 24-hour urine, not just a spot. A spot pH can be very unreliable, just to let you know, but a 24-hour urine is a lot more reliable for the pH. And if it's less than 5.5, you have to treat it. You have to get that pH up, because if you don't get that pH up, the patient will continue to form stones. Number one, they can form uric acid stones. Number two, they can form calcium oxalate stones. Until you change that pH, I have many patients who came to me from other urologists, and they said, my other urologist can't stop the stones. I look at the 24-hour urine. I said, did they ever treat the low pH? They said, what? Is it the low pH? Did they ever treat that? They said, no, they didn't tell. They said it was normal. No, you got to treat the low pH. That's why you're forming stones. Let's look at this 55-year-old man. He underwent uroscopy for a radiolucent stone. Hint, hint, hint. They're making uric acid stones, right? Radiolucent. You check the 24-hour urine after surgery, and it shows the following. Number one, you can see that they don't urinate enough, 1.75, so they need more fluid. Number two, the pH is low, 5.35. That's the problem. That's why they're making uric acid stones. The pH is too low. So the treatment consists of what? Increased fluid and potassium citrate. You've got to get that pH above 5.5. And by now, you know, of course, you're going to repeat the 24-hour urine. Otherwise, why bother, right? So you repeat the 24-hour urine, and sure enough, the pH is now high because they're on potassium citrate. That's great. You fixed the problem. Uh-oh, look what happened here. Now the uric acid level's high. Now what do? They make uric acid stones. You put them on potassium citrate, and the uric acid level went up. What should we do? Okay, I'm trying to trick you here, actually. You shouldn't do anything. This is to be expected. When you have a uric acid stone former and you raise the pH, the uric acid will then dissolve into the urine. And when it dissolves, the uric acid level will go up because it's no longer a stone. It's now just dissolving, floating around in the urine. So of course the uric acid level will be high. That's to be expected. You don't need to do anything. You fixed the problem. The pH was the problem. The stone is now dissolved in the urine, and when it dissolves, the uric acid level goes up. It's to be expected. Don't need to do anything. Normal response to alkalization. Okay, that's my lecture, and I'll take any questions if you have any questions for me.
Great. That's a very wonderful presentation, Dr. Sir. Most times I've struggled with this 24-hour urine analysis and its interpretation. And today really enlightened me very much how to interpret and work with it. Most times I would have just done one without repeating to know what is happening. And I'm sure my colleagues will also share similar experiences. From what you presented, what it means is that we should have a grasp of almost all the dyes, our regular dyes in Ghana, what they contain and how much they contain, right?
Yeah.
It's not as sure as you are sure about the kind of foods you have and the contents that each of them has. And I think from now onwards we have to collaborate with our dietitians so that we can really know our staple diets, what is contained in it, and how. So my question is, do you usually do this all by yourself or it's in collaboration with other multidisciplinary team members?
Exactly. I have a dietitian that I collaborate with.
Hmm.
So all my patients will see the dietitian afterwards. So I think that's very helpful because to be honest, as a doctor, I'm not very good at helping people with their diet. The dietitian is very good. Most doctors, we're not trained to help people modify their diet. So, yeah, I agree with you actually. Yeah. The other thing I wanted to say was sometimes the patient, has a 24-hour urine and the results look normal, right? Or the other urologist says it's normal. And they said, well, what do you think? I said, well, it can't be normal. You formed a kidney stone. So if you formed a kidney stone, I don't care what the piece of paper says, it's abnormal. Let's make it better. So, if the citrate is 500, let's make it 600. If the total volume is 2.5 liters, let's make it 3 liters. It can't be normal. You made a kidney stone, so let's make it better. A lot of times they say it's normal. It's not normal. You formed a kidney stone. It has to be better.
Okay. So my next question is, do you frequently then treat most of your patients on medical explosive therapies alone? Or do you, if they come and it's asymptomatic, do you try to dissolve it using medical manipulations?
So, okay. So if a patient has an asymptomatic stone and they don't need surgery, I always try to use diet to help them, not dissolve the stone, but to prevent the stone. If I repeat the 24-hour urine and I cannot change the numbers, then I will go to medicine. However, if you are talking about patients who have kidney stones that need to be treated, then most of them are surgically treated. To remove the stones, usually I can't dissolve them unless they're uric acid stones. The calcium stones, as you know, and the infection stones and calcium phosphate, they have to be removed. If the patient wants them removed, they have to be surgically removed typically.
Because my experience has also been that I don't have a lithotripsy in any form of it. So when I see symptomatic stones, what I usually would do is to place a ureteric stent by cystoscopy. And if there's hydronephrosis, everything, you see that it resolves over time. And then we start with this, our medical expulsive therapies. Basically, these are herbal-based Indian pharmacological agents, which we give them. Some of them, surprisingly, you repeat a scan after a while, and the stone has disappeared.
Yes.
And then you can take out your stents.
So with that situation, I agree. Yes, if it's in the ureter, then giving an alpha blocker, that is my practice also. I thought you meant for the like a stone in the kidney, but if it's in the ureter, absolutely, I would give them an alpha blocker and wait.
Okay, let me open the floor for the other participants to also ask whatever question they have. I can see Dr. Moore. Can you hear me? And Kathy, can you unmute the participants, or they should unmute themselves?
They'll have to unmute themselves.
Come again?
The participants will have to unmute themselves.
Okay, okay. So Dr. Moore, if you can hear me, kindly unmute your microphone and make a comment.
Yeah, that was a wonderful presentation. I don't have any question for him.
Okay.
I have a question for you. I have a question for you guys, Dr. Adai. How often do you use pharmacotherapy, and what type of therapies do you use?
Dr. Say, I was just telling you, it's usually herbal based. We have herbal based, and these drugs are like there's a phyto agents, phytotherapy from India mostly. That's what we've been using most often. We have different brands, calcrate, cystone. That has been our main backbone. Of course, in Ghana here, in Kolebu and in 37, in Accra, these are other major hospitals in Ghana. They have the lithotripsy machine, the laser lithotripsy machine. And so they are able to, as it were, crush their stones easily. By even that, because of long waiting times, you find that invariably patients receive these phytotherapies in one way or the other. And in some situations, once the stent is in there, the stones may get dissolved over time.
Yeah, it's very interesting. I'd love to learn what medications you're using.
Yeah, I mentioned some of them. Cystone, CYST, like Cystone. These are drugs coming from India. They haven't been found to be 100% effective, because sometimes the patient is put on it and for months, the stone even keeps increasing in size. And so then we have to refer for ESWL or URS with laser lithotripsy. But I'm currently undertaking a research on all the stones that I've managed over the last 2 years. The symptomatic ones, I put in a stent, a ureteric stent, and I put them on these medications. Some of them have disappeared, but I don't have the numbers, so I'm working on it. Dr. Roland Azolia, you are there. Can you unmute your microphone and make a comment or ask a question?
I have another question
Roland?
for you.
Okay.
I have a question for you.
Dr. Say, I'm listening.
How often do you do percutaneous stone removal, PCNL?
Unfortunately, in my institution, we don't at all. In Kolebu and the Premier Hospital in Ghana, I know they do it. They do it, but we haven't had, because we don't even have the lithotripsy machine. It's difficult to pursue some of these lines of treatments. Yeah.
But you have a laser, right?
We don't currently have a laser. In Kumasi, what we use is the ESWL machine.
How about for ureteroscopy? What do you use?
We don't have currently the ballistic. We have the pneumatic
Oh, yeah.
lithotripter, which a friend owned privately by one of my colleagues. So there are times you've used the pneumatic lithotripter to crush some ureteric stones. Yeah.
Because I do mostly PCNL and a lot of mini PCNL, and we use a pneumatic to break up the stone with the PCNL.
Oh, okay.
So maybe one day if I come, I can bring the equipment and show you. And I do a lot of teaching here in the United States, and people come to learn from me.
Wonderful.
Yeah,
you really appreciate you. We would appreciate you coming for an in-person workshop with us in the years to come. Hopefully, very soon, that we can learn from you. Yeah.
Do you
and Kati,
ever
I know
use
you facilitate that for us.
Do you use ultrasound or X-rays? What type of imaging inside the operating room do you use? Fluoroscopy or ultrasound?
As I said, we use ultrasound mostly, but there are friends from the Premier Hospital here, Dr. Mawina Oyote. Dr. Oyote, are you there?
Yes, I'm here.
Please share your experience with us, what you do in Kolebu.
Oh, I left Kolebu last year.
I didn't know you have left.
Okay. Yeah, I'm in home now. But when I was there, we were using the fluoroscopy.
Okay.
The CM.
The CM, yeah.
Oh, good. Yeah.
Okay.
We use a combination of ultrasound and CM for the access, the PCNL access. I teach a lot of ultrasound-based access at the AUA course and here.
I think I left before they started doing the PCNL.
Okay.
Yeah.
Okay. That's fine. But as Dr. Sir is saying, it would be great to have you around for this kind of hands-on workshop training workshop.
Yeah. Okay.
That's right.
Yes, we do a lot of them here, so I have a lot of practice with it. So I would be happy to show you.
Okay.
Wonderful.
Thank you.
Right. Thank you, Dr. Ayote. Dr. Otubuatin, you are there. Do you want to share a comment or two?
No, I'm good.
You are good. Thank you.
Yeah, I'm good.
Great. Is the general there, Dr. Roland? You want to make a comment? Roland? Okay, I can see
Hey, Dr.
after
Dye,
here.
I have another question for you. Do you have a lot of bladder stones?
I won't say a lot, but in my practice, I've seen quite a significant number of bladder stones, quite significant number of bladder stones in association with lower urinary tract obstruction from BPH. It's quite a common occurrence that we see.
Yeah.
And most of them are removed at the time of prostatectomy, mostly open prostatectomy though.
Do you want to see something interesting here? Actually, I will show you something. Hold on. I operated on a can you see the slides?
Yeah.
I operated on a dolphin here a couple of years ago.
A dolphin?
Dolphin, and she was a mother, and she was hyperkalemic. She was in kidney failure. And this is her kidney stone on ultrasound. She had hydronephrosis, bilateral ureteral stones.
You mean the dolphin that is in the
SeaWorld. In the SeaWorld here at the park.
Wow, I see.
And so then one stone passed, but the other one did not pass. So we operated on her to remove the stone. I performed cystoscopy. And I tried to put a stent in her.
That's very interesting, I must say.
Yes, I'm trying to get the video up, and I put the stent in her, but it was, can you see that?
I only see I'm not seeing a video. I'm just seeing what you put up first.
Oh, well, anyway, I put the stent in her, and it was, let me try it again. And it was, can you see this?
Yes, now I can see that.
I put the stent in her, but it was too short, and then it got sucked up into her ureter, and I lost the stent. And they said, now what? I said, I don't know. I said, why don't you put her back into the water? I will come back tomorrow with a ureteroscope. So I brought a ureteroscope the next day, and I did it again with a holmium laser this time. And
wow.
And then I went back up there, and I hold on. How come it's not playing? I went and broke up the kidney stone. It's taking forever.
And you were able to retrieve the migrated stents?
Yes, hold on 1 second. Hold on 1 second, I will show you. Can you see the screen?
Yes. Yes, I can.
Yes. So the stone fell down the distal ureter into the bladder. So I broke up the stone with a laser. The dolphin was awake. She was not anesthetized, and she was very upset.
Definitely should be.
She was in a lot of pain at this point.
And why is it that he wasn't anesthetized?
Because she was so weak.
You are afraid you might lose her.
Yes. And so then I put the scope into the ureter.
And the ureter seems far bigger than that of a normal human being, right?
Looks normal. And there was a stent. I said, oh, there's a stent. And
That's
so I
right.
was going to remove the stent, but then I said, oh, there's another stone there.
That's right.
So then I had to break up that stone too.
That's right. And that's interesting.
And we saved her, actually. She lived. She was going to die. She had already gone into cardiac arrest one time.
Wow.
And so now when I go to SeaWorld, they always say, you can come anytime you want with your family.
For free.
For free, yes. Always.
When I visit you, take me to the SeaWorld.
Yes, when you come to visit, I will take you to SeaWorld. And I want to show you something. Oh, here.
Wonderful, wonderful.
Here, I will show you this. So this is my wife.
Okay. And is she being transported by
the dolphin? That is the dolphin we saved. This is the dolphin that I operated on. This is my daughter.
I can see the dolphin is really grateful.
She's very happy.
Wonderful, wonderful.
That's my daughter.
Great, wonderful. That's
Okay.
interesting. Wonderful, great. I think you'll be privileged to have you join one of the IVU training workshops to Ghana to come and offer us this hands-on training. And
then you come to San Diego and we'll go to SeaWorld.
Great, great. I will by all means. And I would like to use this opportunity to say a big thank you. Today you have really educated us. I mean, if I learned nothing at all, I know that with a dive.
If you have a dolphin with stones, who to call? You know to call me.
Of course, I know more than that.
That is your biggest lesson, Dr. Adai.
We are very grateful to you. We are really grateful for such a wonderful presentation. And we will be calling on you from time to time until we see you in person in Kumasi for that hands-on training workshop.
When do you think the next IVU will be?
We are still working on it. Hopefully early next year, first quarter of next year. We usually do it in February, towards the end of February, sometimes last week in February.
Mm-hmm.
And so this coming year, 2021, we're planning for that workshop.
Oh, did you have my colleague come last year, Dr. Buckley?
Dr. Buckley?
She's a reconstructionist. No?
No. We had Dr. Yu from Boston. You met him? Have you met Dr. Yu, Richard Yu from Boston Children's Hospital?
No.
Oh, such a wonderful guy. Buckley, no.
Yeah, it's okay. I thought she went there to Ghana.
Or maybe my colleagues. It's a lady, right?
Huh?
She's a lady.
Mm-hmm.
It's a lady, it's a female.
Yeah.
I think she did, but I don't call her Buckley. Is it Dr. Chin? Is it Dr. Chin? I think she did. She comes from Santiago. Yeah, right. Yeah, you are right. But we did not refer to. Is this her?
Can you see her?
No, she didn't come to Ghana.
No?
No, not this one. She's not been here yet.
Okay.
She's not been here yet. I'm sure you come before her.
She is a very good reconstructionist.
Is it a pediatric urologist?
She's not
Oh,
pediatric, but she's adult reconstruction.
that would be
Like,
nice.
you know, for urethroplasties and
Mm,
fistula repair.
okay,
Uh,
okay, okay.
She's very good at, you know, benign disease.
I see. Do you do any other thing apart from the stones?
Yeah, I can do some benign disease, strictures,
Mm,
urethral reconstruction, kidney.
okay,
Yeah.
wonderful. So we'll be in contact with IVU to see, because usually the team that comes in the early part of the year, they come with the mindset of reconstructive urology, pediatric reconstructive urology, like hypospadias and all.
I have colleagues who maybe can come if you want to from the pediatric side too.
Wonderful, wonderful. But I mean, for all these years, we've been having hypospadia repair, and so we made it known to IVU that we really want to do something extra, like the stones management, the uro-oncology. And so if this year there was no COVID, if COVID had not interrupted our program, I think around this time in the year, October, we're going to have a workshop in either reconstructive or uro-oncology. And so going forward, I know you will be needing your help and assistance in that direction. Yeah.
Yeah, and maybe I can bring my colleagues with me too.
And when you come in, can you do us a favor, a big favor? Come and donate the little laser machine you use on the dolphin. If you are
Sure.
no more using it.
Yeah, no problem.
We'll be happy to have it.
I might get arrested, but yeah, no problem.
Yeah, grateful to you, Dr. Sir. Very, very grateful. I'll be sending you mails from time to time.
Okay. Nice to meet you.
I think we have to extend this friendship beyond today.
Yes, for sure.
Yes.
Here is, you know, if you want my information, and this is my information, email.
Yes, let me write that thing down.
Oh, we can do WhatsApp too. WhatsApp, hold on.
Yeah, a WhatsApp is better for me. One 619 694 0817. Great.
Yeah, send me a message, Dr. Adai.
I will do that. Thank you very much, Dr. Sir.
You guys have a great day. It was very nice to meet you.
It's been nice meeting you too. Have a wonderful day yourself. Thank you very much.
I can't wait to come visit you.
Great. I can't wait to host you.
Yeah, okay.
Great. Thank you very much.
Bye, Katie. Thanks for your help today.
Yeah, thank you so much, Dr. Sir, and thank you, Dr. Adai.
Great.
Okay.
Great. Thank you very much, Kathy. I'll be communicating with you.
Okay.
Bye, everyone. Thank you.
Thank you.
Bye, thank you.